All right, so I have my timer, so I won't go over. So, I'm very appreciative to two individuals that are in this room, Dr. Treppel and both Dr. D'Amico. As I was finishing my residency, Dr. Treppel called me to his office one day, and I had actually applied for the surgery department position, and he told me he had wanted me to be a biomechanics role because Dr. Cusack and Dr. Sek were retiring. So Dr. Cusack, I have to thank also because he helped me do this project that you're about to see. And it's been a little over a year now since he's retired, and I've successfully taken all of his patients on, and now I'm the director or the leader of the Gait Lab. So thank you, Dr. Treppel, for seeing something in me that I didn't see in myself, and Dr. D'Amico for training me as I am. So today we're going to be talking about total contact casting, and it was a project I did in my Gait Lab. I have no disclosures. I just want a nice life for my Labubus. So we're going to be talking about the objectives. You'll know as we go through it. So what is total contact casting? Dr. Jacobs just explained it very thoroughly. It's really a casting technique designed to offload the ulcers. There's obviously some contraindications for it that have been reviewed already. You can make it from scratch or use prefab. Prefab's a little bit more expensive, so it depends what kind of clinic you're in or if you have good reps with you. And why is this good? Because it really allows the patient to assume somewhat of normal daily activities as much as possible, right? Not swimming, though. I've had a patient do that before, too. So it's very effective in reducing the plantar ulcerations, but you can't forget that the ulceration was caused by something, right? So the biomechanical exam, even on ulcerative diabetics, neurotrophic, neuropathic people, is very, very important, and it's valuable once the ulcer heals. So what is computer-assisted gait analysis? Dr. D'Amico just did a wonderful lecture, so we're going to be diving into it a little bit more. This is straight from their website. This is the system that I use. I don't use the standing mat. I do an in-shoe pressure system where it attaches to the patient's cuffs, and there's also a waistband. I don't really like the standing mat, but if that's all you have, then that's all you have, and that's great too. But people who focus on pressure alone and you don't look at the phasic data, the spatiotemporal parameters, are really missing a large portion of what's going on. It's a lot more than just pressure. There's the center of force line, and then you can see how things are loading, and it really tells you something. So this is a patient that I grabbed that was barefoot. This is a true definition of hypermobility, especially on the right greater than left. You see that there's no pressure under the first, a lot of pressure on the second, and some pressure on the hallux. So that is a true definition of hypermobility. Also notice in the heels are loading in valgus. Relatively, these center of force lines are even, so that's good, but there's much to be improved. So people who say barefoot walking's good for you don't really know what they're talking about. So, revisiting the total contact cast, this is an interesting article where they used a different system that does not look at phasic data. It just looks at peak pressure using a total contact cast, and they did find that it reduced. So nobody has done it using my system yet. And this is Dr. Armstrong's article. It's pretty good, where they looked at the total contact cast, a half shoe, and an air cast, and what did they find? Not shocking, like florals for spring. TCC had healed a higher portion of the diabetic foot ulcerations in a shorter amount of time compared to the other modalities. And this is another Dr. Armstrong article. Peak foot pressures influence the healing time of diabetic foot ulcerations treated with total contact casts, and it showed the successful reduction in peak pressures. But what about the contralateral limb? What about custom foot orthotics for the contralateral limb? What about the limb length discrepancy that develops from wearing a cam boot on one side? Nobody talks about that. So this is just to review how you do it. Patients often placed in prone if they're able to, right? Sometimes grandma and grandpa can't go into prone anymore. But for an example, if it's a submet 2 ulceration, you want to make sure the arch contact is full to offload it successfully. And that's what I did. I pretended that I had a submet 2 ulceration. So the consequences are, for those of you that know what a cam boot looks like, they vary they vary in thickness of the heel. Some of them range to 1 inch, some of them range into 1.75 inches. The taller ones are a little bit heavier. That's a little bit harder to negate the limb length discrepancy that develops from that. It's uneven weight from right to left. The cam boot is heavy. The unaffected limb effectively becomes the shorter limb as a result, and the lighter limb. The cam boot height ranges from 1.4 as the smallest to 1.75, and due to this, the superstructure is going to have some implications. And this is a cheap leveler that you can do for the contralateral limb, and that's what I did. So this is me walking. This is my barefoot walking. You could see my heels loaded a lot in valgus, and my barefoot walk from 2023. I was also a little bit heavier then. You could see I'm really loading my forefoot, left greater than right, and I have the IPJ of my hallux. And the center of force line is very medial on both, indicating that I have a flat foot and a collapsing arch, which I do. And that's what this shows as well. But I was utilizing orthotics. That's why my symmetry from left to right was pretty good, because Dr. D'Amico helped me design my own orthotics. So I did negate that pretty well, but barefoot I was able to maintain my positional change, but I should not be barefoot. I need to be in an orthotic and a shoe. And the waveforms, the amplitudes, the phasic data, symmetry, timing is everything, and I cannot stress that enough. I see so many papers and so many people that attempt to reproduce this, and all they do is look at the peak pressure analysis, but it's really the timing of everything that is going to make both limbs function symmetrically, and that's going to prevent arthritis or arthritic formations in the superstructure, whether that's the ankle, knee, hip, or low back. So just bear with me. We're going to be doing, I walked a lot that day. We did a few different gait tests. So this is now me. You saw the barefoot. This is me in my Oxford alone without an orthotic. And you could see it is a little bit better. I have more surface area contact from my heel to my forefoot, but I still have a lot of increased pressure in the ball of my foot. And also my heels are loading in valgus, which is not good as well. And I realized after this test I needed a new Oxford that day because I was bending too much in the ball of my foot, and I bought a new Oxford shortly after that. And further, I didn't have a Met pad on my orthotic, and I added one shortly after that on my next cast. But relatively, there was some asymmetry, but it wasn't the worst. So now, this is me with my Oxford and my custom foot orthotic. This custom foot orthotic, as an Oxford, is very streamlined and narrow. It ended just before the metatarsal heads, so it controlled my foot very well. It just stopped before the metatarsal head, so that's why it wasn't alleviating the forefoot. But take note that the heel valgus is reduced completely. So this is me in my Oxford with the orthotic and my deformities, but I still had a lot of peak pressure in my forefoot. So, and then actually what ended happening because I needed a new shoe is that I still had a lot sub-Met too, even with my orthotic. So I needed a new Oxford and I needed to add a Met pad, which I did subsequently. So, what did I do? Because I don't have diabetes and I don't have a submet 2 ulceration. So we added a circular felt under my right foot submet 2 area to mimic me having an ulceration, because it'll be increased pressure there. So now on the right side, I was in a cam boot, and on the left side was my Oxford again, without the orthotic. And this is what most of you send patients out with, without any device inside either or. This actually, for right now, has nothing to do with a total contact cast because it's not applied yet. But this is what happens when a patient wears a cam boot that's not level on the contralateral limb and you don't have an orthotic on the other side. This is the worst my left foot ever looked. So the center of force line is not good. My heel valgus is very increased, and the forefoot pressure is increased even further. Now on the right side, so the right side is functioning very long. The cam boot's very effective at reducing the forefoot pressure though, I will give it that. But it is heavier and my right limb is longer, and I don't have a leveler or an even up type device on my left side. And you can really see the asymmetry and the really lack of optimization that's occurring. And further, my propulsion was very low on my right, which is good. That's what the cam boot's supposed to do. It's a triple rocker, right? And how does it work? Because it's really all heel contact, heel midfoot contact, no forefoot pressure, which is good. However, my heel time is 24 percentage points longer than my left. Anyone who walks in a cam boot without having the left foot being level and even is going to get low back pain as a symptom and potentially some type of arthritis develop. And I actually know someone who refused to wear a leveler on the contralateral limb, and then they had to have a laminectomy, and their Trendelenburg gait finally resolved. So now what did I do? We did the right lower extremity cam boot and then the left Oxford with the CFO. So now I have an orthotic on my left. I still don't have a leveler. Look at how amazing that is, actually. And it made the right foot perform better as well in the cam boot just by adding the Oxford on the left side. This center of force line's a little bit better. The forefoot pressure is also reduced, and it actually made the right foot that doesn't have any device inside of it, just the cam boot and my submet 2 fake ulceration. But you do notice that my right heel is still loading in valgus. So the contralateral limb is important to consider, as well as the limb that you're treating. Don't forget about the other foot. So the cam boot side's still very long. What am I going to do about that? This is why you need the leveler, because you want both limbs to function symmetrically. So now the right lower extremity still had the cam boot. I did the left lower extremity Oxford and an even up without the orthotic. This is how a lot of you guys leave patients. I didn't do the full amount of the leveler, I just did half. Look at how bad my left foot is performing. There's no contact between the heel and the forefoot. A lot of increased pressure. My heel's loading in valgus severely on both. It's actually, even though it's elevated, because the orthotic is not in it, I would argue my right foot in the cam boot is performing worse than it did before. Much worse without the left's custom foot orthotic. The right lower extremity propulsion is increased as a result of that, which is what we didn't want. And the left lower extremity compensations are affecting the timing and torquing the superstructure of the limb. So now we have the right lower extremity cam boot, the left Oxford with the orthotic and an even up ½ inch, not the full amount. This looks pretty good now, but I know there's another slide, so it could be better. But look how good this is. So we didn't do the even up to the full amount. The center of force line became a little bit longer on the right side. The heel is not loading as much in valgus anymore, and the left foot is slim and trim now, but we can still improve it a little bit better by attempting to level off the limbs. The center of force, the custom foot orthotic on the left is the only variable from the prior study that we just did, and there was much improvement on the left custom foot orthotic, and it improved the right lower extremity peak pressure where my submet 2 ulceration was. And this forefoot is much better now. And notice how with the custom foot orthotic and the leveler, not the full amount, we actually narrowed the gap a little bit but on the heel time, so we made both limbs attempt to function more evenly. So now this is just a picture of me in the total contact cast. I hadn't added the total contact cast yet. Now I'm in the total contact cast. And this is me. Dr. Cusack took this picture. This is his hand. He wanted to see how he got it vertical. So now on the right side, I have the right lower extremity cam boot and a total contact cast and the sensors below it. On the left, I have the Oxford without the custom foot orthotic and the even up for the full amount. So you see, without the custom foot orthotic on the left, I have no connection to the heel and the midfoot. You really do have to consider the left foot, or the contralateral limb for that matter, for whatever side that you're treating the ulceration on, right? These are not isolated things. So there's no custom foot orthotic on the left, causing a much poorer center of force line. You see how much I load medially. The heel on the left is loading in valgus, but the cam boot and the total contact cast is doing a pretty good job. That looks like a nice blue ocean. And then further, the compensations are worse than the primary deformity, I would say, on this side, especially for the left, because the left is allowed to compensate without a corrective custom foot orthotic and the right can't. There is decreased pressure on the right lower extremity submet 2, which was the goal, but at what cost to the contralateral limb? And that's really what I want you to focus on. Now we have the right lower extremity cam boot, total contact with the sensor below, and the left foot has the Oxford and my custom foot orthotic and the even up to the full amount. Doesn't this look the best? It speaks for itself. This is a beautiful blue ocean. So this is the ideal scenario. This is the custom foot orthotic on the contralateral limb. The limbs are even as possible. The right and left have the lowest pressure and shortest center of force lines, which is the goal. And there's no peak pressure submet 2. This is the ulceration that I was trying to mimic. So this is really the importance of custom foot orthotics on the contralateral limb, as well as doing a leveler on the contralateral limb. Why? Because it's more functional than without the CFO. Remember the prior slide? The amplitudes mimic a more normal gait function, just like Dr. D'Amico showed, a double humped camel. The heel time difference is likely due to the weight of the right lower extremity. So I really couldn't get it more of a narrow gap. That's because not only does the total contact cast have some weight, but the cam boot has some weight too. So I really can't make up for that difference. But we close the gap as much as possible. And then further, on the left, maybe I should have done a custom foot orthotic that goes to the toes, but this one stopped prior to the metatarsal head. Then just for funsies, we did a sensor inside of the total contact cast and the same scenario on the left side, just to see if it could pick up. And it actually did. The system didn't really understand what was going on, but the submet 2 ulceration was barely there. So it really does work, total contact casting. So this is the same scenario, and it really did work. It's just it wasn't able to pick up the numbers on the right to compare it to the numbers to the left. So, and the sensors really weren't designed for this or intended for this, so that's why the data is a little skewed. But if you look at submet 2 on the waveforms, it's pretty low. And this was actually the narrowest gap from left to right. And this is another picture as well, comparing it. So, and there was left heel eversion, and submet 2 was adequately dispersed via the total contact cast. So this is before. This is with me barefoot, and this is after. So it speaks for itself, right? That's a beautiful blue ocean, and that's what you want. So in summary, you need an even up on the contralateral limb. LLD has many consequences. The cam boot alone is effective in reducing center of force beyond the midfoot. The total contact cast is effective in offloading the forefoot and ulceration. But don't forget about the contralateral limb, and don't forget about a leveler. And with that, ladies and gentlemen, thank you. And have a nice day. Email me for questions.